First, I'd like to thank the STEM for Life Foundation and the Pontifical Council for inviting me to speak today about the use of mesenchymal stem cells in orthopedics. We've been at this longer than most anybody else, about the last 8 years, and we've learned a lot in that 8 years that I'd like to share today. So today we're going to talk about not embryonic stem cells, but adult stem cells. Also, the two different types of stem cells that will be featured in some of the treatments that we've performed through the years are mesenchymal stem cells and hematopoietic stem cells. And this is a stem cell conference, so there's really no need to go into more than that. There are really two ways that medical innovation occurs. The first way is probably one more familiar to many of the speakers here at this conference, and that is there's some basic lab finding. That basic lab finding, like a mesenchymal stem cell can produce cartilage, is then tested in animals, and sure enough, it seems to work. Mesenchymal stem cells in animal models do repair cartilage. Then a small clinical trial, like a phase 1 FDA trial, is put together, and then larger trials, and eventually a new drug or product is created, as long as all of that structure is passed through. Now, there's a completely different way in which medical innovation occurs that might be less familiar to some of the people speaking here this week. I call that bottom up, or you could also call it the physician innovation pathway, because the problem with the pharma innovation pathway is that it's crazy expensive, it's defined by the business plan, and it's centralized. Physician innovation occurs pretty differently. We see a doctor who notices that something seems to work, and then he tries that in a few more patients, obviously discussing with the patients what the risks and benefits might be. And eventually more patients are tried and studies are performed, first small studies, then larger studies, and eventually, if it passes through all of the rigor of science, you get a new therapy or treatment. So two very different ways of going about this. The bottom-up approach is more inefficient. It's a lot cheaper. It's defined by medical need, not by the business plan, because it's a very inexpensive way to innovate, whereas the pharma method is a very expensive way to innovate, and it's more long tail, more consistent with how we view life, the universe, and everything in the 21st century. If we look at the published research and published FDA trials, there's an awful lot of patients that have been treated with cultured bone marrow mesenchymal stem cells. This was as of October in the National Library of Medicine. That many patients have been treated with cultured. That many patients have been treated with just a non-cultured mesenchymal stem cell fraction. And then, as you can see, for other different stem cell types, not much in the way of publication exists. So our goal has always been to replace the need for more invasive surgery by injecting biologics. It's a very simple concept. I'd rather see you get an injection of stem cells 5 years from now than a knee replacement. And so what we practice and what we're developing is really an entire field of what we call interventional orthopedics rather than surgical orthopedics. So this is an example of interventional orthopedics. You can see this very pretty series of pictures. You can see a needle coming off to the right. This is someone's shoulder. This is a slap lesion. And you can see this dark stuff here developing as it loops around from the end of the needle, and that's where the cells are being injected directly into a slap lesion. Now, prior to the invention of various imaging technologies like this or musculoskeletal ultrasound, this would have been impossible to do through a needle. You would have to have a scope. But we can now do this through a needle. And if we can do it through a needle, biologics will allow us to do it better through a needle. And we should do it through a needle rather than surgically. So this is our stem cell procedure history. It goes back to 2005. There was some preclinical data showing that mesenchymal stem cells might be effective in orthopedic problems. We then went ahead and did a safety study with 45 patients that went through an IRB. That seemed to work well. We published a few imaging proof of concept case studies in that 2005, 2006, 2007 timeframe. We then started treating patients through a very strict registry process. We've published 2 large safety papers that I'll talk about in a little bit. We've published an efficacy paper, and I'll show you some of that data for knee osteoarthritis. And we've treated more than 1,000 patients and more than 2,000 procedures, all of which have been followed through a strict treatment registry approach. Our procedure is fairly simple. Or at least simple from the standpoint of how I can explain it today. Cells are collected from the bone marrow. We take an IV blood sample and we isolate platelet-rich plasma and/or what's called a platelet lysate. We can then isolate the mesenchymal stem cells in the lab and either inject them back the very same day or grow them to bigger numbers after culturing them for 2 weeks. We call it an SD or same-day procedure when it's the same day. We call it a C or culture procedure when they're cultured to get more. And all patients are tracked by a very strict registry process. So how do same-day isolated stem cells versus cultured stem cells compare head-to-head for knee osteoarthritis? So again, the SD is the same day and the C is the cultured. First, we'll look at just some objective data, mostly MRIs. You can see here up on the top left, this is a knee ACL tear. This red arrow points to what's in the white dash circle up on the left, which is a big tear with some small amount of retraction in the knee ACL. You can see as the MRIs off to the right occur, and those are after treatment, you don't see that break in the ACL anymore, and eventually you see what looks like a normal ACL morphology on the MRI. This is someone who did very well. Again, rather than having that ACL surgically taken out and replaced, all they had was an injection of their own same-day stem cells into that ACL under very exacting imaging guidance. So here we have a shoulder rotator cuff tear. The red arrow on the left points to a very large gap in the rotator cuff. You see a massive amount of swelling, which is all that white stuff on the left. And then on the right, we see a completely different picture. So after the patient's own stem cells have been placed very painstakingly in that rotator cuff tear, and we've done some other things to bring those ends apart, all through a needle and all through injection, this person's rotator cuff tear is healed on the post-op MRI. So again, only an injection, no surgery. Pretty interesting stuff, and this is just same day. If we look at our cultured procedure, this is actually change in meniscus volume on several patients. I've graphed there the age, how long we cultured the cells, and the change in meniscus volume and change in cartilage volume. So as you can see, we're seeing more changes in meniscus volume than we are in cartilage volume in general. But still some changes in cartilage volume. This is a picture of a hole in the cartilage in someone's knee. You can see her on the left, the white dashed circle encircles a hole in the cartilage, and then a smaller hole in the cartilage on the right. Patient did very well with this treatment and has still done very well 5 years out, and only had an injection of her own cultured stem cells into that cartilage area. So now that we've looked at some objective data with MRIs, let's look at what patients tell us. This is data from our registry. So these are a little less severe knee arthritis patients who had an injection only of their own stem cells, no surgery. 184 patients. There's the demographic information up there. Again, this is not randomized controlled trials data, but it is registry data. This is improvement from baseline. So as you can see, almost all patients improve from baseline. And then this is the mean improvement over here to the left. 4 weeks, 3 months, 6 months, 12 months, 18 months. So that's the mean percentage improvement in those patients. If we look at the cultured data, this is now cultured stem cells, no surgery, just an injection, but generally more severe osteoarthritis than the first group. 125 patients in our registry. This is 3-month data, 6 months, 12 months, 18 months, 24 months. They generally do a bit better, even though they've got more severe arthritis with the cultured cells. And this is a head-to-head comparison of the same day versus the cultured, broken down by severity of knee osteoarthritis. So if you look at mild OA, you can see here a pretty good sizable difference there. Moderate OA, again, a difference, but a much bigger difference when you get to the severe osteoarthritis patients. Same day doesn't seem to work as well as cultured. And that's about what you'd expect given what we know. And if you look at our published safety data, we have published 2 large complications papers, 339 patients followed for between 3 months to 4 years. More than 50 research grade MRIs have been taken, and complications were significantly less than surgical alternatives. This up here today, and then we can go on to some questions by the moderators. As far as future research is concerned, we have now 8 years of experience, and we're fairly convinced that we can help patients avoid surgery by injecting their own stem cells. Obviously, we've developed many techniques and quite a bit of knowledge along the way in how to make that work. And we have 3 randomized controlled trials underway because we're not going to hang our hat only on the registry data. We're obviously pulling the trigger on going to the next level and getting the next level of data. So with that, I'd like to wrap up my talk today. Again, I really appreciate being invited here. I said last year in my talk that my mom always wanted a priest. She never got a priest from her 6 boys. So maybe lecturing at the Vatican is as close as she's ever going to get. But I think she's pretty happy with that. So thank you very much, and we'll move on to questions.